Hello, everybody. My name is Marc Peeters, and welcome to Medscape in the Clinic. I'm currently the CEO of the Antwerp University Hospital in Antwerp, Belgium, and also full professor at the Department of Oncology. My colleague, Kanwal Raghav, will introduce himself. Please, Kanwal.
Thank you, Mark. Hi, everyone. I'm Kanwal Raghav. I'm one of the associate professors in the Department of GI Medical Oncology at the University of Texas MD Anderson Cancer Center. Really excited to be on the show today.
So today we will discuss together the different strategies and also the sequence and of course the challenges that we have in the current therapies with metastatic colorectal cancer patients. We have several options, and one of these options are oral TKI therapies. But the question is how to sequence in real life setting. And that's the reason why we're going to discuss at least two cases. I welcome the audience and also ask them to have some questions, because we want to have a debate and to see what is the scope in your practice at home to treat these patients, and also to have some sequence in the therapies that we have available, not only in the US, but also in Europe. So the first thing that we see is that we have different lines of treatment, like we already discussed. Of course, the patients that receive more lines of treatments have a better outcome. Throughout the world, the median overall survival is between 15, but some patients have longer overall survival if they receive more lines of treatment. For example, if a patient receives 7 lines of treatment, it can be up to 37 months in median overall survival. This is not only the drugs that they are receiving, but also the multidisciplinary approach that currently is in most of the centers available to follow these patients up in their treatment strategies. So the question is, how can we try to have a management based on several factors that we have available, not only the performance status, but also the fact that we are dealing with a very heterogeneous disease. We have seen recently some ideas on sightness of disease, the fact that patients have multiple sites of metastasis might have an impact on the treatment selection. But also the performance status of the patient might influence the treatment in a given patient. So the first case, and I hand over to Kanwal to introduce the first case of this session, is a 65-year-old male patient. Kanwal, it is your turn to...
Yeah, thank you, Mark. So, we'll start with this case one. This is not an uncommon scenario that we would see in the clinic. A 65-year-old gentleman initially presented with stage 3 colon cancer, which was RAS mutated, right-sided, MMR proficient, HER2 negative. But then developed recurrence after after receiving 6 months of adjuvant FOLFOX, 1 year later. The adjuvant FOLFOX went well, but of course the patient has some grade 2 neuropathy, which is persistent right now. The recurrence is in form of very small liver lesions and then some lung metastases. And the patient was started on first-line treatment with for metastatic disease with bevacizumab and FOLFIRI, so 5-FU and irinotecan, and received almost 9 months of this treatment with some initial response and then stable disease. But the course was complicated by cytopenias requiring multiple dose reduction, growth factor support, and one episode of febrile neutropenia. Today, the CEA levels have started to rise again. Imaging is now showing some minor disease progression with a new liver lesion, but the patient still maintains their performance status. So the bigger question that arises is that this patient is now interested in a break from infused therapies. therapies, from IV therapies. Um, and the obvious question is, what would be typically the best option at this point? And can oral therapy be used to achieve or maintain stable disease as a bridge to systemic chemotherapy? Especially when the patient has low volume disease, and what would you do in case the patient has bulky disease? In this patient, obviously, one of the options that we have is a reintroduction of FOLFOX as a second-line chemo for metastatic disease. There was a 1-year disease-free interval, so it's reasonable. However, there are two challenges to that kind of chemo re-challenge. Number one, the patient has some toxicity issues that are complicating the picture, particularly neutropenia. And then the second issue is the presence of the grade 2 neuropathy, which will get worse in case of a re-challenge with oxaliplatin. And one of the more important criteria is the patient is also now tired of chemotherapy, has been getting chemotherapy for almost 15 months, and wants to stay off of IV medications. Obviously, there are some third-line options, more specifically regorafenib, as we have seen from the CORRECT study, TAS-102, as we've seen from RESOURCE study, TAS-102 plus BEV, which is not purely an oral regime, but an oral plus IV, which would be the SUNLIGHT trial. And then we have, some insight into the newly FDA-approved fruquintinib from the FRESCO-2 study. Most of these have, of course, been in patients who have already progressed or are intolerant to 5-FU, irinotecan, oxaliplatin-based treatments in the metastatic line. But there are a couple of studies that have looked at the role of moving these therapies up into the second line study. One of the examples is the TAS plus BEV versus FOLFIRI and BEV. This was a study done by Kuboki et al. It was, it was a randomized trial. It was designed as a non-inferiority trial, but unfortunately failed to meet its primary endpoint of median PFS. And the median PFS in that study was about, the median OS in that study was about 14.8 versus 18.1 months. So second line introduction failed to do better than BEV and FOLFIRI. Another study was a single arm non-randomized trial, which was the STREAM study, which was presented at GI ASCO, and basically it compared regorafenib monotherapy as a sort of bridge to second line treatment. This was the primary endpoint of this study was progression-free survival at 6 months. The median PFS that was seen was about 3.6 months, but the study still failed to meet its primary endpoint because the proportion of patients that were progression-free at about 6 months were only 30%. However, in that regorafenib study, from the STREAM analysis, there were patients that were long benefiters from treatment who had median PFS of about 10.2 months. These were patients that have either solitary site of disease or lung-only metastases, where the disease tends to be more indolent. And despite the short-term PFS that was seen in the STREAM, there was no compromise of getting subsequent lines of therapy. And nearly 80% of patients went on to get chemotherapy after that. So, those are, a couple of trials, but I would love to hear your thought on the role of oral TKIs in this disease stabilization, especially when patients are not looking for IV medications or are having problems with bone marrow suppression.
Yeah, I think it's an excellent question because we are facing every day the same problem that you just covered in the case that you presented. Patients are not progressive, stable disease, but are tired of or have side effects of their chemotherapy. And then the question is, what are the options available? The European situation is somewhat different because we have some drugs available, but for example, in my country, they are linked to the line of treatment that you can give this type of drugs. Some are not available, so we need to be very careful not to introduce some drugs that are not reimbursed in some European countries at the moment. But for example, this case where you have a patient that receive intravenous chemotherapy in combination with one of the biologicals and having an impact on the performance status, especially on the neutrophils, I think there is an option to bridge, like you already mentioned, for a certain period with oral TKIs and to see what the disease is going to do under that treatment with oral TKIs. When the disease is stable and the side effects are under control, I would continue. At the moment that you see either progression or the tolerance is becoming problematic at that moment, I would switch again to one of the therapeutic options like FOLFIRI in a given setting, or if there is no persistent neuropathy, reintroduce, like you mentioned, FOLFOX in that setting. So we have to be very flexible with the options that we have available and think individually what is the best option. For example, you mentioned also TAS-102. If you have a patient where the tolerance of chemotherapy was somewhat difficult, I don't think that TAS-102 at that moment, even in combination with bevacizumab, is the best option.
Right. So, Mark, you brought up a good point about how certain therapies are linked to lines of therapy, right? But it seems like in clinical practice, the concept of lines of therapy in colorectal is becoming increasingly blurred with like using triplet cytotoxics in first-line treatment.
Yeah.
So, for example, in this particular patient, clearly it seems like cytopenias is an issue. So TAS with or without Bev is probably not a good option. So obviously, as sort of like this chemo bridge or bridging to chemo, either regorafenib or fruquintinib, which have, bone marrow suppression of like less than 3%, would probably be an optimal choice to try to stabilize the disease and get some more, chemo-free treatment interval.
Yeah, I think the fact that we are not thinking anymore in lines of treatment is the way that physicians and also the people that are conducting the clinical trials are thinking for the moment. But you have the physicians and you have the reimbursement authorities, and by the end, sometimes we have a debate on the cost of drugs, and that's the reason why people from the reimbursement side are still coming back to lines of treatment, because this is an easy way of thinking, but it is not clinical reality anymore. So we have to be flexible in the options that we have available. And like I already said, based on the individual patient situation and characteristic, decide what is the best option at a given time point for a given patient. And for example, if there is a necessity for a chemotherapy break, I think oral TKIs are a good option to bridge to further intensive therapy if necessary.
Okay.
So I think we can switch to the second case, 55-year-old woman with NRAS mutated colorectal cancer. She received FOLFIRI as the first line, and then in a second line setting FOLFOX plus bevacizumab. Third line was regorafenib, and then the question is, if there is progression, what are the options? My first question to you is whether FOLFIRI is your standard in first line in this patient, 55-year-old, and RAS mutated colorectal cancer. Would you add some biological or start with FOLFOX in that patient?
Our first line option for an NRAS mutated colorectal cancer would, of course, be a biological in combination with chemotherapy. So in most cases, I would either give Bev Folfox or Bev Folfiri, and that would depend on the toxicity profile and patient preferences. Um, I mean, almost invariably, we do not give chemotherapy without a biological.
Mm-hmm. And this is a mutated patient, so let's suppose that you start with FOLFIRI plus bevacizumab. What would your second line, and then after 2 lines of anti-VEGF, this might be an option, would you then go for regorafenib in that setting, or would you switch to TAS-102 in this setting, either in monotherapy or in combination with bevacizumab?
So I think after second line treatment with Bev Folfiri and then Bev Folfox, um, the options are fairly open. It's either regorafenib, fruquintinib, or TAS Bev, or with or TAS with or without Bev. It's hard to choose between these three treatments because there is there's a lack of data that cross compares all these three treatment regimes. They of course have shown activity, all of them. The only one that we know for sure that we should not use unless and until contraindicated is TAS without bevacizumab, because there was a randomized trial, the Sunlight trial, that showed a benefit of adding bevacizumab. um, I think the choice between all of these three treatments depends on multiple factors, as we have discussed. What are the toxicities the patient is having? Does the patient have, requirement for like or preference for a non-IV treatment? Are cytopenias a big issue? Does patient have uncontrolled hypertension or cardiovascular risk factors? Um, so I think it depends from case to case basis.
Yeah.
But the evidence would show that all of them are reasonable alternatives.
We have seen recently some real-world data on different strategies, especially in later line setting. How strong is your feeling on this data? Will this influence your decision? For example, there were some data on a cohort that received Rego or TAS in combination with bevacizumab. Will this influence your clinical decision, or do we absolutely need randomized trial to convince our strategy in a given patient?
I think a well done real world evidence study is actually valuable. I think for it to trump a clean randomized trial, that's always a hard bar to meet, and that depends on like how strong your real world data collection is. um, I know that the Oceros study, which was the prospective observational study, it showed that when you give regorafenib followed by TAS, or TAS Bev followed by regorafenib, or TAS followed by Reg, there was no like major differences between the overall survival of these patients, barring the ones that got TAS, right? Obviously, because of the combination of TAS Bev that works. So I think the critical thing there is the lessons that I get from this is I should be able to get patients through multiple lines of treatment. And the more lines of treatment they get, the better their survival is.
Mm-hmm.
But whether this actually tells me which drug to use or not depends on, again, the clinical factors that we've discussed before.
Yeah. Kanwal, we had a question in the chat. There is the cost of the drugs, but also the cost of the biomarkers. At what time points in the treatment strategy do you perform your biomarkers, and what is your standard set of biomarkers?
Yeah, so we perform biomarker estimation in all patients with metastatic disease right at the onset. So first line metastatic. There are multiple reasons behind this. Is that it helps you set up the treatment plan for the patient for later on. The standard sets of biomarker is, of course, MSI, or MMR testing. We definitely get, I mean, we are doing expanded NGS panel, so it gives us a lot of information. But I think that the basic information that comes out and jumps at us is your MSI, your RAS status, BRAF mutation status, HER2, because there are distinct treatment and clinical trials ongoing, which we are very passionate about, and we are trying to enroll patients on them. But also it affects clinical management in real time. We, beyond that, the the only other testing that we often do is some biopsies or liquid biopsies, particularly after progression, especially on targeted treatments, because we want to determine resistance mechanisms that have arisen. And there is also some value in anti-EGFR rechallenge. So I think that is the spectrum of biomarkers that we do. But I'm not aware of any biomarkers specifically that help you with third line treatment. Your thoughts on that?
So probably at that moment you decide based on the factors that we just discussed, the lines of treatment, the tolerance of the treatment, and the performance of the patients. And I think one of the things that we also want to cover is the side effect profile. The question is, do we see differences? So what are the common adverse events that we see? And do we see differences between the TKIs that we have available currently? Kanwal, what is the most important thing that arterial hypertension and food?
Yeah, I mean, I think that they're all very different drugs. At least in clinic, it appears very different. The TAS-BEV combination is essentially a third line chemotherapy option. I see it that way. There's a lot of bone marrow suppression that we see. Sometimes that bone marrow suppression appears to be like higher than what you see with like bev-FOLFIRI or bev-FOLFOX in first line setting. I think in the TAS-BEV versus the FOLFIRI-BEV, the neutropenia rate was about as high as like 60-70% in the TAS-BEV arm compared to like maybe 40-50% in like the FOLFIRI-BEV arm. For Fruquintinib, I am definitely concerned about the hypertension. That is the side effect that we see commonly, and this is not the kind of hypertension that you see with bevacizumab or regorafenib, at least in the clinic. These can be like some high-grade hypertension. So I'm very cautious about starting something like that in a patient who already has history of uncontrolled hypertension or has lots of hypertension from like prior VEGF exposure. And with regorafenib, I think the main side effects is the hand-foot, skin reaction, rash, and diarrhea. So those are I think the key side effects that I think of when I'm treating these patients. But I think the more important thing is we've gotten better at managing it. So like how do you really manage these patients? How do you counsel these patients in your clinic when it comes to these side effects?
Yeah, I think the most important point is that we have a team of not only physicians but also nurses that are following these patients very closely, also at home. Some devices where we can have home monitoring of the patients and communicate very easily with them. A second is at the moment that you have side effects that are, for example, skin toxicity grade 3, then we have some dermatologist that is involved to see whether we can have some ideas on treatment. And I think what we didn't discuss is the flexibility of the dosing, especially with Rego. The starting of the correct study was a higher dose, a fixed dose, and we have seen some problems with the tolerance. Having the flexibility, especially starting low and then increasing the dose, and having the same impact on the outcome of the patient, I think it's important to have this type of strategies in our daily clinic. So it's not only the flexibility on which drug, but also the flexibility how to manage these drugs and also to manage the side effects. So for me, the key is good follow-up of the patient, a multidisciplinary team, not only for the efficacy, but also for the side effect management. And I must say, with the flexibility of the dosing, then most of the patients can continue the treatment without major problems. And what is also important in this setting, trying to maintain the quality of life as long as possible.
Yeah, I couldn't agree more. I think, we have gotten into the habit of actually seeing these patients more frequently than we do actually on systemic chemotherapy. And the Redo study was a good example of a study in this setting wherein, you have disease stability, you have some control over disease, but the side effects are significant. I mean, the grade 3 side effects, to be fair, are, upwards of like 50-60% in most of these drugs. So trying to show or establish that you could escalate the dose without actually, it didn't seem like it was compromising the efficacy or the outcomes. So I think that's become sort of our standard practice when it comes to regorafenib, and I'm hoping that there are more guidance about those modifications in TAS and TAS-BEV combination as well as fruquintinib.
Do you sometimes have the discussion with your patients openly that there are three options? What is the preference of the patient?
Almost invariably, barring a clinical trial, which of course is our preference, not just in this setting, but any setting, we do discuss this openly because the toxicity, like we said, the toxicity profiles are so different. And if I have a patient who has uncontrolled hypertension or cardiovascular risk factors, I'm not going to not tell them about fruquintinib. I will but I will discuss the clinical benefit and the risk ratio. I think that always helps people not just choose the current line of treatment, but also sort of be prepared for what comes later, right? Because if I tell them, okay, this is the only option that you have, then they may not understand that the aim is not just to get the one option right now. This is just a sequencing question, and at some point of time they will get the other drugs also.
Yeah. We have been treating these patients for several years on both sides of the ocean. Is it really important to have these oral TKIs in the treatment armamentarium of today to treat our patients with metastatic colorectal cancer for several reasons, not only for efficacy? Is it a major improvement?
Yeah, I mean, I think as we reach that third line of treatment, response is not always the only criteria. Keeping some disease stability, maintaining quality of life, is also a particular criteria. So I think as we are developing better drugs through clinical trials, these are still drugs that have shown survival benefits in randomized trials, and therefore patients should get access to these drugs. But you're right. I mean, I cannot. I think it's still too early to comment on the cost and the value and the utility of these drugs in this setting.
Okay. I think we have 1 minute left. What are your final message to the audience, Kanwal?
Open discussions regarding treatment options in third or fourth line setting. Appropriate sequencing based on a variety of patient factors and not just one particular factor. And then first and foremost, always try to move patients towards clinical trials.
Yeah, that's true. And do you have some view on the future? What is coming out of the clinical trials?
Yeah, I think these are exciting times, Mark. You've been a part of all of these developments. I think we are moving into eras of personalization of immunotherapy in the MSS cohort. We're starting to see some success with next generation antibody drug conjugates. We're starting to get targeted therapies into more first line options. So I'm really excited for our patients, and and hoping for a better and brighter future.
Okay. Thank you very much. I think we are ending this session. Thank you for the audience. Thank you for the discussion that we had today. And you have seen the QR code of a Medscape session that we have previous that is for the moment available at the website of Medscape. Thank you very much.
Thank you, Marc.